I'm really fortunate to be joined today by two outstanding people, Eric Harkness to my immediate right and Dr. Victor Wu to my far right. Eric hails from Columbus, Ohio. He's been in Tennessee for many years, began really as one of the architects of our state health plan, initially in our comptroller's office and then in our state health planning office, initially with our Medicaid agency in Tennessee called TennCare, and then that was moved over by executive order to the Department of Health. And Eric is now the founding director of the first Office of Health Policy in Tennessee, in the Tennessee Department of Health. And Dr. Victor Wu is an internist. He hails from Kingsport, Tennessee. He has had a very interesting career to include stints as a White House Fellow, also in the Office of the Secretary of HHS, and currently as the Chief Medical Officer of the Tennessee Healthcare Financing Administration, which in Tennessee is known as TennCare, a very large agency. Let me just kind of, note, the Tennessee Department of Health, which is my agency, about a $620 million agency, about 3,500 souls, health departments in all 95 counties, provide about direct services for about 1 in 6 Tennesseans a year, and regulate the entire healthcare industry and much of the food and hospitality industry in Tennessee. TennCare, about a 450-person organization, about $11.5 billion with a B agency, which will be common in most states, very large agency budgetarily, and is responsible for about 1.5 million covered lives. So two agencies, both cabinet level agencies, and in Tennessee, there are about 22 commissioners that report to the governor, and the director of TennCare is one of those. So we're here to kind of talk about a particular partnership and a particular story. I think when we think about where we're at globally in this, this really is a story about how we build bridges and how we build bridges to the health that we all envision. I think we are beginning to understand that we can't treat our way to health. That health care is really not the answer to what we all really want, which is health. And most of us want health care to be there when we need it, but we really want to be healthy. Somebody said in one of my last sessions, health is wealth. So when we think about that, while we may all recognize that, we also may recognize we've got this $3.2 trillion industry in the United States of America. If it were a country all by itself, it'd be the 5th or 6th largest economy in the world, period. That entity is not going to simply go quietly into the good night as we kind of change our focus from care to prevention and health. So we have to really think about how we build bridges into the future that we envision. And that's going to take time. It's going to take some experimentation. Not all of those experiments will be successful, but we have to have the courage to try them. And it's going to take the right market incentives and the right policy incentives and the political will to make that happen. And this story that we're about to tell is really in that vein. A particular story about how we begin to do some health system reform. So I'm going to turn now to Dr. Wu and ask him to kind of give us an overview of the system reform efforts in Tennessee and his perspective on the Episodes of Care initiative, the very innovative initiative that his agency began.
Great, thanks Dr. Dreisner, and it's a great opportunity to be here with you all. So just to give a little bit of context and background before I let Eric talk a lot about how really the Department of Health has been a leader in setting up a partnership with us over at the Medicaid agency. In 2013, Governor Haslam, who's the governor of Tennessee, set forth a very bold and committed vision to move healthcare payments in Tennessee toward value. I think it's a story and a path and a strategy that many states are undertaking as it is now. But he made it very clear. He made a public speech about it. He talked about how it was important for us to be thinking about outcomes, about value, about how population health and public health ultimately will drive us toward for every dollar that we spend, we're going to maximize how that dollar is spent in terms of developing true outcomes and clinical quality. And so as part of that initiative, TennCare, the Medicaid agency, underwent kind of a strategic plan, and through the help of a SIM grant through the Center for Medicare and Medicaid Innovation, came up with a three-pronged strategy. And the strategy really was to try to reshape the way that care was delivered in Tennessee. And to Dr. Dreiser's point, certainly was focused on care delivery, but with an eye, hopefully, of how do we begin to prevent some of that care that needs to be given and take it out of maybe some less appropriate settings. And so the three parts of the strategy were primary care transformation, episodes of care, and then long-term support and services reform. And so I'll spend just a couple seconds to talk about the first and the third, but then really focus the rest of the time on episodes of care. So the PCMH strategy was the core of our primary care transformation. And so many of you out there all are familiar with the primary patient-centered medical homes. And so what we did was focus on how to transform primary care as well as mental health and develop a program called HealthLink for the mental health homes. And in essence, set up a PCMH for both physical as well as a PCMH type for mental health, and then try to find ways to integrate the two. That really is to set up the basis and the foundation for preventative care, for a relationship with your physician, and that's one part of the strategy. The second part was episodes, which was really focused on the acute care, so any care that was delivered in hospitals and ERs, things that when there are opportunities for and times where you need to access acute care, how do we begin to have an accountable quarterback or an accountable provider or accountable facility? Think about the journey of that patient. Sure, they may take care of them in the ER, but that we know for a patient that isn't the only time that episode of care is really going to impact their health. It's the time before leading to the ER. It's the time after the ER. It's the follow-up. It's the rehab. If it's a surgery, how do you get them healthy prior to the surgery? During the surgery, how do you make sure there's quality outcomes? After the surgery, how do you make sure they're getting the right rehab services, getting plugged back into PCMH? And so we thought it was important for these acute episodes of care to really find an accountable and a true one entity or provider to look at to say, you're going to be really helping to think about the journey of that patient and how do we derive value and make sure that outcome and the dollar being spent on that care is really spent wisely. And then the last part of that, you can't talk about primary care and acute care episodes if you don't also think about the long-term support services, especially for Medicaid and the Medicaid population that we have. And so we really wanted to shift a lot of focus toward the post-acute care continuum and how to think about long-term support services. And so all of this was being driven by Governor Haslam's vision, not only for the Medicaid program, but also for the state health plan and all the employees on the state health plan. But certainly Medicaid just being a very large player in Tennessee and covering about 20 to 25% of our state's population was kind of the way we wanted to lead it. So this was a really, really big undertaking. It is a multi-year strategy. We have about 75 episodes of care that we want to ultimately roll out. Things like, a knee or a hip replacement. It might be things like diabetes exacerbation or COPD asthma exacerbation. It could be, other infectious diseases like an HIV, new acute HIV, or skin and soft tissue infection. So it's really looking at opportunities in clinical times where acute care is needed and appropriate, and how do we really begin to drive value there. And so that's really the story in the long-term vision. We've got about 35 plus episodes live now, and the process along the way has been not without its challenges and not without, physicians love change, right? That's what they love more than anything else. And so think about all the providers and all the change management that has had to occur, and the Department of Health has been a tremendous partner in that, and I'll let Eric kind of speak to kind of how that partnership developed. But that's really the episodes of care strategy as part of a three-prong approach for us to change the way that healthcare is being paid for and delivered in the state of Tennessee.
And let me just kind of add one clarification, because you heard state health plan twice. There's the state health plan, which is the overarching plan for how we get to healthy lives in Tennessee. It's actually in our state code, and it's we're directed to create that by the legislature, and the governor signs it. And the state health plan that Victor was referring to is the plan that covers all state employees. So 44,000 or so state employees, about 250,000 all told with dependents. Interestingly, the budget of that entity is almost twice that of the budget of my entire agency. So speaking of the cost of care versus the cost of prevention.
Yeah.
And I think it was, part of Governor Haslam's vision, as you mentioned, was we're a big payer, and if we're going to do these episodes of care, we don't want just to do this for Medicaid, but we want the private insurers and the exchange players to come along with us. And they did, although as you mentioned, change management is always a challenge. Right. So Eric, can you talk to us a little bit about the process and the vision for the Department of Health's engagement with our sister agency?
Sure. Well, thank you, Dr. Dreisner and Dr. Wu. That was a great intro to the work that we're trying to do in partnership. And I think it's important to mention that the Department of Health was invited to the table by TennCare. This wasn't public health going in and knocking the door down. And we'll get into this in a few minutes, I think, in our discussion. But after our years of cultivation of a relationship, the timing was right. We had the Centers for Medicare and Medicaid Innovation floating out there, the State Innovation Model grant opportunity. And so TennCare invited us, Dr. Dreisner and I got to go to Baltimore with the TennCare leadership, other leaders in state government, to go and make our pitch to CMMI. And so we really got to be part of Tennessee's delivery system reform efforts from the very beginning, and I think that was important. It took a little while for us to figure out what that partnership really looked like, though, and how would it work. So one thing, that the episodes strategy utilizes are technical advisory groups. Every single episode has a tag made up of subject matter experts, of specialist providers who live that every single day, who are commenting on the quality measures, on the design of the episode, to say, well, this is going to work, or no, this is really impossible, we can't ever implement this. It's sort of a reality check on the episode. And if you put yourself in the shoes of a provider participating in one of those tags, thinking about the episode for which you are going to be held accountable as a quarterback of care for that particular episode, you're going to want to define that episode as narrowly as possible, because you want to be on the hook for as little as you can. But from a public health, from a population health standpoint, you want to do the opposite. You want to elongate that episode. You want to have more of a holistic view of what's happening before, during, and after that episode. And so we were trying to think about how do we get that perspective? How do we get that voice into the process? And Dr. Dreisner and our previous director of TennCare, Darren Gordon, struck an agreement where Darren was inviting our participation in the process. And we just had to figure out what did that look like. And so one of our earliest ideas was, well, we have a lot of really great clinicians in the Department of Health. Let's have a clinician from TDH serve on every single tag. But that didn't really work out, because the tags are actually, they're a hot ticket in Tennessee. If you're a provider, you want to serve on a tag. And so we would have a clinician who is likely not a specialist in that area serving on a tag, filling up a seat. The other problem with that is if we had a disagreement from a Department of Health policy perspective, we didn't want to be airing our dirty laundry in public in front of all these other providers. And so what we wound up doing is creating a process where we would start with a little paragraph description of the episode, and we would create a team of interdisciplinary folks from the Department of Health, community, public health educators, all the way up to nurse practitioners and physicians, to look at each episode and create from an evidence base, whether it's the Prevention Services Task Force or American Academy of Pediatric policy statements or whatever it might be, try to draw from the existing literature what's out there on that particular episode, pull it together, and figure out what's most relevant for TennCare to consider for this episode. And so we created this episodes review committee that is able to provide pre-decisional input that then goes into the framework for the design that is presented to the tag. So, and this is offered as you're welcome to this. This is our best ideas, but we recognize that TennCare, you have a program to implement, and you have considerations that go beyond what we know about and what we can comment on. And so we want you to feel free to take these comments or leave them. And so far, we've done this now with two waves of episodes. And the vast majority of our recommendations have been adopted, and others have kind of been included as quality measures that aren't necessarily out there for a provider to be dinged or given a bonus payment, but as FYI measures, basically, so that providers can know about what's going on, even if we don't have the best data source to be able to monitor that. So it really was a journey. It took a number of different iterations to get to the point where now we have a process where the Department of Health can provide pre-decisional input on TennCare's process, and in doing so, trying to draw on available evidence and condense that down into what's most relevant. What are the 2 to 4 recommendations we can make on each episode that are going to be most helpful?
Great, thank you. Let me just amplify one point. There's a really important question that you have to ask yourself, I think, practically when you're trying to create this kind of collaboration, and that is, who is the customer? And you heard Eric say, here's our best advice. But in this case, our Medicaid partners clearly are customer, and we want to provide them with the best stuff we can, but they're not going to buy it all, and that just has to be okay. And we can't see things from their perspective. We're giving them good information, and they're the customer in this case, and that's a really important thing to think about. So, Victor, how's that working out for us?
It's great. I'm up here on a panel with these guys, right? So I don't have another option of what to say. No, I'm kidding. It's really been a wonderful partnership. It's really been fantastic, and I think there's many value add that the Department of Health has brought. I think a couple I might highlight, just to echo what Eric said. I think those pre-decisional input that they've had for us has been really valuable. But really, I think the benefit isn't just, here's some more things to think about. It's really that as partners, they help us push us on the public health lens, and I think as practitioners in the room, providers in the room, the TAG meeting that Eric mentioned, they're all practicing physicians that are in their specialty, and doctors and nurses and PAs and providers, they all kind of think in numerators, and public health thinks in denominators. And so they have the ability for the Department of Health to come in to give specific recommendations that push us to think about the public health lens and the downstream consequences, as well as the upstream prevention is really valuable, and something that is a voice. And to Eric and Dr. Dreisner's point, we don't always take the recommendations, and I think there's a chance to have a dialogue around that when we don't. But in the last wave, I know there, for example, one of the ones we did an episode was around soft skin and tissue infections, and so one of the key quality metrics and suggestions was to think about inappropriate antibiotic use in these, and that's a very public health issue. Certainly, when providers think about setting up one prescription for antibiotic, it might be inappropriate, it might not, but one person probably doesn't make a difference. But when you think about that as on the whole for the state of Tennessee, that's a great kind of practical example of how they've pushed us to think about some of the bigger impact that you can have from a public health perspective. So I think that's the first one, is really to have that public health lens. I think a second tremendous value and impact here is actually around data, and Eric didn't mention this, and Dr. Dreisner has been really focal on this as well, but the Department of Health has tons of great databases, and we've actually looked for ways to incorporate using data sources from TDH, that the Tennessee Department of Health, that providers are already putting into registries in order to kind of align and to reduce provider burden, but really to augment a lot of the public health surveillance items as well. So breast cancer, we had a breast cancer episode, and so we're using the breast cancer registry as part of our episodes of care, quality measuring and metrics and data source for that. Another one is around immunizations, and so some of our childhood episodes and asthma and looking at immunization in the Tennessee Immunization Registry. So another example of how data source that TDH is in charge of, we've really found ways, I think, to help strengthen our ability to deliver a more seamless experience to our providers in Tennessee that see our Medicaid patients. But on top of that, I hope is supporting the robustness of their databases as well. And the last one I would just say is, again, you hear us, I think, alluding to it a little bit, but episodes and delivery system transformation is not. I think up here on this stage, we all think there's tremendous value and potential in it, but that's not the view of everyone in the state of Tennessee in terms of providers on the ground and hospital systems and some of our other key stakeholders. And so just the ability to have another agency bring their voice in alignment is just is I think invaluable. And the fact that we've had discussions prior to tags, discussions along the way from the very beginning. You've heard I wasn't at the agency at that point, but when Dr. Dreisner went up in support of our SIM initiative, just to have that alignment from the beginning, it's just another set of friends that can help tell the same story of why this is important, why this matters for the state, and why this is going to push our state toward a more value-based healthcare delivery system. And that is just, again, something that it's nice to have friends in the room. And it's great to have friends, within your sister agency. And so that's really been invaluable. So those, I think, are just three of the most important parts. And again, to Dr. Dreisner's point, I think it is true. I think that we are tasked. The Medicaid agency is responsible for the episode strategy and for the delivery payment reform. But to understand what your partners are bringing to the table and where they're better than you are at certain things, and to lean on their voice in those opportunities really helps. I think keeps us in our swim lanes, and Dr. Dreisner uses that term a lot, but helps us stay in our swim lane. We know that these guys are experts in public health, and so we need them at the table. We need their voice, and to understand that, yes, certainly we may not take all the recommendations, but for them to be champions in public health for us, these are things that you cannot separate. They're part and parcel with each other. Delivery of care plus public health plus population health, that is the future. It has to be integrated, and to recognize that about your partners is really important.
Thanks, Dr. Wu. Really good insights. Yeah, I think about the swim lanes, and I think about, occasionally you'll kick the mask off the person ahead of you, but you're behind you, but you really don't want to do that.
That's
yeah.
right.
So,
Swim faster, that's the...
Swim faster.
Swim faster.
So you mentioned, Eric, that we had, we didn't get out of the gate with a perfect process, and we learned some things along the way. And since this is the practical playbook, maybe reflect on some of the lessons learned, and if somebody else, if another, whether you're engaging, NGO to NGO, where you have different, agendas and constituencies, or you're engaging state agency to state agency or state agency to NGO. What are some of the generalizable lessons learned that folks might take away from our experience?
Sure. Well, as we reflect on this process, I think there are a couple of universal principles that we've picked up along the way that I think are applicable to any collaboration. And the first, I think, Dr. Wu hit it on the head, is friendship, building trust and having a relationship. And it's really difficult to do this level of work and this level of collaboration if you do not have a basis of trust. And so it's really important to be able to know your partner, know what their interests are, and know what they're trying to get at, and how you can serve them as a customer. And so then finding those areas of practical collaboration, being able to, based on that trust, based on that knowledge, deliver the right product. It's not enough to say, hey, I'm here to help. You need to provide something that's actually a practical help to your partner, because collaboration for collaboration's sake doesn't really work. You can't just say, sing Kumbaya and pretend that everything's okay. A third area, I think, is that public health looked at Medicaid as a customer, and along that vein, thinking about the customer's needs and how do we design a product that is saleable and is relevant to what TennCare needs. And then finally, it doesn't happen all at once. It takes several iterations, it takes several attempts and tries to get to the point where, number one, you have that trust and relationship, you have the understanding about the customer needs, and then you actually have the process in place to fulfill that customer requirement. It took us 2 years, really, of getting to this point. It's not automatic. And then even before we had the discussions about episodes of care, there were years and years of repairing, frankly, a somewhat tattered relationship between the health department and TennCare. Things weren't always, haven't always been as close as we have been, but thanks to a lot of leadership on both ends, we're now closer than I think we've ever been between our two sister agencies. And so who knows what the next opportunity is going to be, but we're going to be in a much better position to take advantage of that because of our ongoing collaboration, because of that investment and relationship, and because of the years and years of work that has gone into building trust and helping both sides know that, hey, we've got your back, we're here to support you, and we're not going to go out and air our dirty laundry in public. We aren't going to take it personally when you don't accept 100% of our recommendations, but we're here to serve you. We have a perspective that we know that you value, and so it's our privilege and honor to get to participate in this process together. A really critical, important process for the state, and one that we don't take lightly. And so it's a hot ticket to be on the Department of Health Episodes Review Committee, and we feed them lunch. That's what they get out of the deal. So, food always brings everybody to the table.
So thank you, guys. That was terrific. Thank you, guys. And I think now we have a little bit of time. I'll just make one final point, and I just kind of amplify what Eric said about the trial and error. Every collaboration doesn't work out. I kind of think about it a little bit like panning for gold. You dip the pan in the stream, and you wish it around, and there may be nothing. Next time, maybe you get a flake, and every once in a while, you get that nugget. But you got to be happy with flakes, and it's okay if you have a few dips and there's nothing in there. It's all right. Not everything's going to work out. But one of the things you get when every time you dip that pan is experience. You're building relationships. You're kind of building understanding, and that makes it easier for things to pan out when there are flakes in the bottom of the pan. So we got a question back there. Hey, I know that guy.
I don't think this is on. Maybe you could.
Dr. Frazier.
Hello, welcome. Great story. Thanks for sharing that. I think it's really inspiring and what we want to see in all our states and territories. I'm Mike Frazier with ASK, though. What leadership did you need from the governor's office, and did you need any policy approved through your General Assembly or legislature to support the partnership, or was this sort of goodwill, everybody gets lunch, and it's the right thing to do approach? One of the things we're hearing from a lot of different states and territories is they all want to do the right thing, but there are policy and legislative barriers. And I just wondered if around data sharing or budget or authorities, was there gray areas that needed to be resolved or on your list to resolve in the future?
So with respect to this specific collaboration, I think it's important to note that SIM2, because of a lot of work of folks in the public health enterprise, including the CDC, with HHS, and Victor was a part of that at that time, the public health agencies were required to go with their Medicaid agencies in order to get that funding, and that also, there was another win in there for us in that we were able to goose our state health planning process, and that provided us with a lot of other opportunities. But from a legislative standpoint, from a administration support standpoint, it was really more the right thing to do. The Governor Haslam, he really didn't twist anybody's arms. He just said, this is important to me. I'll just tell you, he's a great leader and a terrific manager, great boss. He doesn't have to lean on you. You just understand this is a priority, and we're a part of that, and we're a part of the team, and when we go along. But we didn't really need any specific authorization to do that. And I would also say that leadership does matter, and the governor does expect his commissioners and his folks to work together as a team, and that's tremendously facilitative as well.
Great, thanks. One quick follow-up. How important is having that state health improvement plan codified in legislative language to sort of serve as a foundation? I don't think I've heard many states have that kind of formal inclusion of their state health improvement plan in legislative language, and maybe that is a great idea for other states to sort of bring this forward.
Yeah, and Eric might speak to that. I'll just say one thing about that, and that is, I think it's really important, and it's a great opportunity. Interestingly, backstory, when Eric was working in the comptroller's office, he identified a gap, and his reward was having to fix it.
Yeah, that was one of our findings, actually, in a report we did on how we finance healthcare for the uninsured in Tennessee. Was we have this law on the books calling for a comprehensive state health improvement plan, and there's no one staffed to do it. So we called out the Department of Finance and Administration, and the moral of the story is be careful what you ask for. You might be asked to do it. So, so I got in on the ground floor of building the state health plan in Tennessee, and I'll say, yes, it's been really helpful and important to have that in our state code. However, that's not enough. And we've gone through a journey with the state health plan over the years, now almost 10 years, of finding out how can this plan actually be relevant to everyday people. We always said all along, we don't want to have a plan that just sits on the shelf. We don't want to just be in our ivory tower and tell people what they should do. And yet that's how I think a lot of state plans end up being organized. It's, we will accomplish X by 2020, and then there's no real path to actually get there. And someone on the ground, either in a local health agency or in public housing or transportation, much less, really doesn't see the relevance of how do they fit into helping to achieve that goal. And so what SIM 2 gave us was an opportunity to rethink our state health plan. And so rather than having this kind of top-down, very prescriptive plan, we've kind of replaced it with more of a framework, with a set of guiding questions that anyone, anywhere can use. A dirty little secret is, we're all about health in all policies. But in certain parts of the country, when you put the word health and policy together, it kind of scares a lot of folks. And so we came up with more of a backdoor approach to get people in any context to be able to think about health without realizing that they're really thinking about health policy. So those three guiding questions are, number one, are we creating and improving opportunities for optimal health for all? Are we moving upstream towards prevention? And are we learning from and teaching others? So these are kind of three basic questions that whether you're a legislative committee, you're a school board, you're a business, you are a transportation planning group, you can think about the action that's before you and then think about how it relates back to those three questions. And in that way, we're kind of hoping to trying to get everyone across the state to think about health and through those questions and answering them, move in generally the same direction, moving upstream, moving towards tapping into the evidence base, moving towards creating opportunities for optimal health for all. So that's been the journey of our state health plan. It's been a fun and fascinating and windy road, but one that I think is an experience where other states, if we can move away from that top-down prescriptive planning process, it's always been inclusive of people to come up with those goals, but finding a way that is more of a framework that suits the needs of individuals and groups in their own context, to help them, give them a reference point and a framework to move towards health, then we're going to be in a much better position going forward.
Great answer. Thanks, Eric.
I think this is on. I'm not. There we go. You answered one of the questions I had, which is it's the managing down and managing up. And so you just answered the managing down, because I was thinking of Tennessee as a pretty red state, and big culture wars we're having as a nature around, as a nation around health and healthcare delivery and services for the uninsured and the like. How can you? So you talked about the managing down, really helpful. How can you now manage up and out and help our nation come to where we need to be to care for people, to do the prevention and the upstream, what you just said? How do you take those same three questions and get the federal administration and the rest of our politics more aligned so we can get to yes?
Well, it looks like Dr. Wu really wants to answer.
Yeah, this we're a country that works really well together right now. Is that not true? No, I think it's certainly challenging, and I think there's a lot of uncertainty in Medicaid as it is. I mean, there's a lot of uncertainty, generally speaking, I think, in terms of funding for a lot of the public health initiatives, but for Medicaid particularly, there's been a lot of focus on what the next iteration of how the Medicaid program will look for the country, and what some of the principles that will be coming out of the current Trump administration will be to help guide the states in that movement. I think certainly it is easy to kind of sit back and try to hope for some certainty and clarity to come forward. But in the meantime, at least from our perspective in the agency, I don't know how many conferences myself or Dr. Long, who's our director, or Brooke Staverman, who leads our strategic planning and innovation group, have gone to talk about episodes in the last couple of months. And so I think there's a lot of, there's believe it or not, there actually are a lot of common ground themes. I think as it is, every state, at least I'll speak just for myself and from a Medicaid perspective, Medicaid is almost always the top line item budget for a state's budget. And so there is a tremendous amount of will to understand and learn from other states. I don't know how many times I've called up another state to say, what are you doing in this realm? You're doing well, I've heard that. So I think there is a spirit of collaboration that lies at the state level. I think the national politics storyline is very, very challenging. But at the state level, I think red or blue, people pick up the phone all the time and talk about it. And there's ways to really to do that well. And so I think in order to do that, you have to find I think some key messages that are rooted in operational and tactical successes, as opposed to philosophical and kind of big picture storylines that you're telling. And so for us, a lot of our questions are, well, how did you make your managed care organizations in your contracts implement delivery system reform? And so, there may be a different perspective on what delivery system reform is the right way to do it, whether you have a red or a blue perspective, it doesn't matter. But what is very common ground is, how do you actually make managed care move forward in implementing your strategy at a state level? And so those are the types of, I think, common areas that if you can show value and have a discussion around tactical, operational areas of companionship, then you can begin to engage in a larger discussion of philosophical and kind of strategic vision. I hope that's helpful, but certainly something that we've seen in Tennessee that's been very successful for us.
I would just add to that. Oh, sorry, go ahead.
Just to hit home on Dr. Wu on his comment that I think the states are very practical. The state level is sort of a sweet spot in terms of the magnitude of your scope, the ability to affect change, and the willingness to listen to the experience and advice of other states. Regardless of whether you're red or blue, I think the state level is where a lot of change can happen. Change can kind of get bogged down at the federal level, and when change happens, it can be big and can affect everybody. But day in and day out, I think it's the state level where we're wanting to learn from others. And so, the other piece and learning from and sharing more about our top-down, bottom-up approach is that we're still early on in this journey. There's some components of our plan that aren't yet finalized, and so we're going through the public engagement process to try to hammer that down. And so I think we're already engaging with the National Academy of Medicine, Practical Playbook, other venues where we can be engaged with other states who are at the same point, because we're all kind of in the same boat together. And so we want to be engaged, we want to be having that conversation and not just kind of do it in our own little silo. So in that way, we're hoping that we can share what we can learn, and we also recognize we do not have a monopoly on truth and facts. And so we're very eager to learn from others.
Two great answers. I would just underscore that sweet spot. State is both, many states are both policy and implementation, which is really, frankly, a lot of fun. Because you can think the thoughts and you can do the deeds, and you're very accountable for them. And that's a kind of a remarkable place to be. All change is local, but where the state is can really facilitate local communities having an impact and moving the needle on the culture of health that we're all seeking. And that's exciting. It was actually fun to hear both of your answers. Yeah. Other questions?
Ted Winslow from Ohio. go, and I think I'll come live. There you go. Hey, thanks for your leadership in Tennessee. We look to you for how we can work better together. I wanted to give a real-life example of how not to do things and see how we could avoid that in the future, and that is about 6 months ago, I was approached by our Department of Health and said, we got a great idea. We want to use CDC funds to get at uncontrolled hypertension. Can you enroll as many federally qualified health centers as possible in the state to help go through a training process so we can improve outcomes? I said, absolutely, great idea. I want to do this. So I went through a long process going through the state, picked the people, started into training. Then 3 weeks ago, I get a call from the Department of Medicaid. So in our state, we have a Department of Health and a Department of Medicaid. They said, we've got a great idea. We want to go at uncontrolled hypertension and see if you can get all your federally qualified health centers into a training project that's based on exactly the same model. And I'm going like, have you guys talked to each other, first of all? And they're using MedTap funds versus using CDC funds, but coming from two different agencies, exactly the same ask. And of course, we're kind of always wondering, why didn't they come at us together, first of all, so interagency collaboration. Secondly, is it possible to combine funds? Because I know sometimes that's a barrier or an issue. So tell us about interagency collaboration and also grant fund combinations that can or can't be a barrier to that. Because it seems like, because now I got to go back to all my members and say, I want exactly the same thing from a different funder and try to enroll a whole group of people in. I would have rather have done the whole thing once, right? And done it much more broadly and had more funding to include more people. How do we avoid that from happening again? And I'm sure it wouldn't happen in Tennessee, but what are the barriers that we need to overcome so that we can miss that?
Well, I would say a couple of things, and Dr. Winslow was formerly the health commissioner in Ohio, and thank you for that service that you did all those years. The way to avoid that is a few phone calls on the front end, although I'd say it's kind of a good problem to have. I mean, it's not uncommon that we have great ideas concurrently, and maybe slightly different ideas on how to execute those. And this is, I guess this is this is one of the most difficult lessons to learn, and that's humility. If you can, turn to your, colleague and say, that's a great idea. How can I support you in that? How can how can I help move that along? And be okay with it not being exactly the way you do it, and exactly the way that you'd like to see it rolled out. And maybe you don't get, you never get 100%, right? But maybe you don't get 80%. Maybe you don't even get 60%. But you get 40%, and you're getting something, and they're getting 70%. That's a win-win. And I think, that's really how we have to think. And so kind of a message to my public health enterprise colleagues, reminding us that we're a, federal public health discretionary spend is about $58 billion total. Secretary Dr. Tom Price has a almost $1 trillion budget. And if you think about that, that's a larger budget than the gross domestic product of all but about 20 nations on the planet. We probably need to just recognize that that's a big book of business and a big thing to say grace over, and approach that with as much humility as we can. And see where we can find points of mutual advantage, and move those forward. And people start trusting us that we're really in it. We're all, we're not red, we're not blue, we're red, white, and blue. We're all in this together. And I think we kind of all want the same things. We want healthy communities for our families. We want livable places. And we just, we want to have life and have it abundantly in our view of it. And we just kind of have to find that point where we can be okay. I'm not saying we should do things that, that are, anathema to, or, anti-science. But I'm saying that we should try and find those areas where we can work together and just be okay with not getting the credit.
One of my favorite quotes on humility is by an Englishman, G.K. Chesterton, and he said, "Angels can fly because they take themselves lightly." And
He does this a lot.
but there's a lot of truth in that, and that this healthcare is a very serious issue. There are a lot of, frankly, there are literally lives at stake. But I think we all do take ourselves a little too seriously. And when you are approaching another agency or wanting to work across sectors or collaboratively, having that humility to say, you know what, I don't know everything and I want to learn from you, and mixing funding sources, sometimes you can, sometimes you can't. It's sort of a case-by-case scenario, but the relationship that we've built with TennCare didn't just happen. It took years and years of effort and lunches and conversations. And so for two sister agencies, even within state government, to be able to get along, it takes some time and investment to build that trust and relationship.
I might just add one practical thought around the interagency kind of duplication, and obviously make sure you follow the Twitters of important people like Dr. Dreisner and Eric over here. No, but it's actually, I think there's a lot of great collaboration at the leadership level, but honestly, for those types of things, the program staff have to know each other, and so especially when there are areas of common working. So I think about the Department of Health, and they're extremely active as they should be in maternal and child health. The Tennessee Medicaid program covers half of all births and a tremendous amount of the children in the state, and so there's a tremendous amount of synergy there. I've had the chance now to get to know the assistant commissioner, and the program staff are starting to get to know each other. That's one of my goals. But because a lot of the time, by the time ideas bubble up to the top, or they're pretty baked, and Dr. Dreisner gives a lot of great strategic thought, but the early planning periods are oftentimes at the program staff level, and if the program staff level don't know what another agency's program staff is doing, that's where I think there's a really great way to make some easy wins in terms of collaboration and alignment. So that spirit of collaboration certainly I think exists, but you have to drive it all the way down the ground, because a lot of times program staff are in their lanes, their heads are down, they're doing what they're supposed to be doing, but to think about how another agency's program staff to build those relationships, so it's an easy call to say, what are you doing on hypertension? What are you doing on funding for hypertension? Oh, you're doing that? I didn't realize that. Let's think about how to do that together.
That's a really critical point, because I said leadership matters, but creating opportunity for leadership at all levels and making sure that you're deliberately allowing some holes in those silos and where the grain can kind of fall out and mingle, and that's from a succession planning standpoint, our times are always limited in these roles. That's the nature of it. Governor's times are always limited. And creating those relationships at the program staff level, those are when those phone calls occur on the front end, and then somebody says to whoever the leader happens to be, hey, they got this idea. What do you think? And so I think that's a really critical, very practical point. No matter where you are, think about the ways that you're creating deliberate opportunities for people that are going to be there for a while, mid-level staff, to get to know each other and to work together.
Over here, John. Ed Hunter at De Beaumont. I want to talk about or ask about swim lanes, which you mentioned earlier and just came back up in Dr. Wu. A lot of the discussion we've had over the last day and a half has been, moving upstream and moving sort of out of the clinic and out of even the medical model. So I'm curious, the further you go upstream, the more swim lanes you're going to have to cross. And I'm wondering about, with the dialogue that you have across TennCare and the health department, to what extent are you able to picture that sort of crossing into other lanes jointly? How do you, how comfortable is the TennCare in moving outside of the Medicaid model and into upstream interventions? And then how do you leverage this relationship to influence others in the state?
That's a great question. If you think about what the Healthcare Finance Administration, Tennessee, has to worry about, 1.5 million people, about a third of our state budget. That's a lot to say grace over, and they've got a lot of people tugging at their sleeves. And I always like to remind myself that, if you're in a state and your Medicaid agency sneezes, all other agencies get a cold because those are entitlement funds and they have to be funded. So that's something we have to think about. Part of our role is to help them reduce demand for their services. And we, I mentioned earlier, we provide a lot of services in our local health departments that take pressure off of that agency. So we're kind of a vendor in that sense as well. That's yet another story of collaboration that goes back many years and has recently been strengthened. But to the precise point of how we move upstream and how we get other state agencies involved, we didn't mention this specifically, but we've developed something called the Livability Collaborative. It's been going a little more than somewhere 1 to 2 years now, almost 2 years. And that was kind of our answer to health in all policies. And it doesn't involve everybody, and it's very deliberately at a mid-level. So people like me say, that's great, go do that. But it's people like Eric and others who come together monthly with our Department of Economic and Community Development, our Housing Administration, our Department of Transportation, and our Mental Health Agency, others, Department of Education, and talk about what kinds of things we can do to move the needle on livability. And that's a kind of a deliberately chosen word, and you kind of see that as you wish to see it, but it's really getting at what we all really want at the end of the day. For our part, in the Department of Health, we've made a really deliberate effort to get outside the walls of our health department, get into our communities, something called the Primary Prevention Initiative that's been going on now for about 6 years, and then just recently, really diving deeply into both promoting physical activity and the built environment, hiring what we call healthy development coordinators in each region of Tennessee, and that's actually been interesting, a lot of interest in that, and a lot of questions, because people are like, oh, these healthy development coordinators, what are they going to do? Doesn't Department of Transportation do that? Isn't that something that the regional planners? So every time you get engaged in these collaborations, these kinds of questions come up, and they're tricky, and you have to navigate them. And I guess that's kind of, I guess the biggest lesson learned is, you just have to keep figuring out practical ways to navigate those areas and develop solutions that people seek without kicking off the swim mask of the people behind you. And they're always going to worry about that. As much as they'd like to see that happen, they're always going to worry about, hey, wait a minute, what about what I'm already doing? Are you going to supplant me? And you just kind of have to know that up front and have the humility to work it out. So it's time for us to wrap up. I really appreciate your attention. Great questions. Thank you to my friends and panelists. They did a great job, and appreciate your attention.
Thank you all.